Hello. Thank you very much for the opportunity of contributing to your meeting, and I'm really sorry that I'm not able to be with you today in person. However, I hope I'm going to be able to say something that's a useful contribution to your debates and discussions about the nature of variation and the sorts of things that health systems can do to reduce it, and in particular, towards the end, how evidence can help us reduce variation. What about the causes of variation? Well, there's a whole series of them, from human fragility, the exercise of personal choice, uncertainty in the evidence base, variable access to resources, lack of knowledge, suboptimal skills, and the life chances that we're born with. And what I want to do is just work my way through those to put a bit more detail on each of them individually. So what about human fragility? Human beings, and health professionals are no exception, aren't machines. Our performance varies from day to day, week to week, sometimes from patient to patient, conversation to conversation. It's just the nature of what we are. We're shot through with, collectively, the full range of human fragility, and it is inevitably going to have an impact on the decisions that we take. And not just decisions as people involved in organising or delivering care, but decisions that we take as patients as well. We're just different. We exercise choice differently. Our values are different. What's important to us about the outcomes of the treatments that are available to us, what's important to us in terms of their adverse effects, matter differently to different people, and that's going to inevitably influence the choice that we make, and therefore the extent to which individual treatments are used in healthcare systems. And we act differently with our health advisors. Even when we're confronted with the same evidence base, the same persuasive arguments, we just vary in terms of what it is that we want. So being human beings just inevitably has an impact. Even if everything else was sorted out, we would have variability in terms of what's actually delivered and ultimately what's achieved by healthcare systems. So what about evidence and uncertainty? Because the evidence base for anything that we do is rarely complete. It's sometimes very convincing, and we're sometimes very easily convinced by it. But frequently it's finely balanced, particularly the evidence for the new things that healthcare systems are confronted with, whether that's new approaches to surgery or new drugs or new devices, new diagnostics being introduced in the system. And where the evidence base is finely balanced, it can be interpreted differently, inevitably, by individuals and indeed by groups whose job it is to act as evidence or information intermediaries. It can be viewed differently by patients and the groups that represent them. Adverse effects illustrated and uncovered by the evidence influence individual choice. And also, uncertainty influences health systems and the investment decisions that they make. Some health systems are structured on a basis that responds immediately to the introduction of something new into or something that's made available to healthcare systems. In other circumstances, much more, where health systems are potentially much more constrained financially, different decisions are taken, more cautious decisions are taken. How uncertainty is treated in healthcare systems inevitably influences what's available and therefore potentially the outcomes that healthcare systems can achieve. And then we've got resource variability, perhaps potentially the most obvious thing that might influence variability in what's available and the outcomes that are achieved by healthcare systems. Obviously, having fewer resources limits choice relative to systems or institutions that have more to make available to patients. But even in systems where the resources are pretty generous, or resourcing is pretty generous, payment systems can still drive poor resource use and inevitably generate variability by incentivizing suboptimal outcomes. So we need to be careful to make assumptions about the extent to which resource constraints impact on variability, as opposed to the way the resources that we've got are actually used. And even national allocation systems like the one in the UK, formula driven to try and secure equity in the availability of resources to compensate for particular population characteristics such as age or disease prevalence, for example, can lead to variability simply because shifting resources around, giving more to one part of the system and less to another, although it might deal with one aspect of inequality in terms of access to resources, has the potential to introduce variability in outcomes by making it more difficult for some other parts of the health system to do the things that they need to do. And then we've got lack of knowledge, and that's both on the part of individual health professionals and health systems, but it's also on the part of patients as well. It's an enormous challenge for organisations and individuals to keep up with the evidence base. It's completely impossible for, generally speaking, for individual patients unless they're really obsessively, as of course many do, are following the evidence for the treatments for perhaps lifelong diseases and conditions that they're living with. There's a huge amount of information. It's growing rapidly all the time. So it's an enormous challenge to keep up to date with that. And you might think, well, that's why we've got evidence intermediaries, organisations like NICE and their equivalents here in New Zealand. But the problem with that is that there are a lot of them and they don't always reach the same conclusions. And sometimes the advice is contradictory. And even where you have groups which involve but are not part of individual professional or patient groups, for example, they're then generating evidence which needs to sit alongside, or information and advice that needs to sit alongside and be judged alongside with the advice that comes from those professional groups and sometimes those patient groups. And that's before you get to the case for individual health technologies that's put forward by manufacturers, by drug companies and device manufacturers. And inevitably, whoever's doing it, any evidence base requires interpretation and judgment. And that involves time and effort and resources to do well. So making sure that there is that capacity to access and to interpret evidence in order to make sure that the information that's needed to secure consistent service delivery and ideally consistent outcomes is available to the people who need it when they need it. And then what about us as individuals and the skill sets that we've got? We're not always good at recognising the limitations of our skill set. And this can be a problem, particularly when health professionals are in such a special position of trust. Few of us, when we're patients, actually, even those of us who are very familiar with healthcare systems and how they work, find it very easy to question or challenge health professionals. So the more that we can make information available to those who are involved in delivering and receiving care, the easier it's going to be for a dialogue between institutions that are employing health professionals and between health professionals and their patients that helps to expose to ourselves the sometimes difficult challenge that we either not got the skills to do something, and we're never going to have the skills to do it, or that we need to train and develop, take the time out to learn about something, to develop new skills in order to make sure that we're doing the best for our patients. Regulation is important in this context, but it's complicated and it's contentious. The data to enable judgments by regulatory bodies isn't always available, or it's incomplete, or it's difficult to interpret. And frankly, health professionals have yet to fully embrace the case for transparency and challenge that will enable a process of regulation to really effectively operate in the interests of patients and in the pursuit of consistency in the availability and the effect of the treatments that are available. And then what about our life chances? Ultimately, of course, there's a limit to what healthcare systems can do to reduce variation. Some of it is simply a function of the cards that we've been dealt with as individuals as a result of where we've been born, the education that we've received, or the economic circumstances of our parents. All these things we know have an immediate and long-lasting impact on our life chances, and they frequently display clear geographic patterns. And this, of course, requires a wider societal effort to resolve over a much longer period than some of the other issues that I've spoken about. But it's a very important influence on the availability, the delivery, and the consistency, ultimately, of the services that we're providing. So just to finish, given my interest in it, how can evidence help to reduce unwanted variation? Well, critically, it can inform those investment and treatment decisions. Without the right kind of information available, without information that allows us to make really discriminating choices as health professionals or as patients, we're simply not going to be able to make the decisions that get the best outcomes for us. And without being able to make that evidence base suitably converted into a resource that can be used by individual health professionals and patients, we're not going to be able to secure the consistency that we're looking for in decisions across our healthcare systems. It reassures patients. If we can say to patients that, notwithstanding all the uncertainty, here's what seems to be the best approach, potentially using patient decision aids to help inform that conversation, then they're going to leave the engagement with us as health professionals, at the very least confident that we've done the best for them, even if they remain uncertain, anxious about where their treatment is going to take them and ultimately what their outcomes are going to be. It empowers our staff. We employ the best people in our society. We employ people whose ambitions are formed by the training that they've got, which itself has been based on research that they will have become familiar with. So we've got a fantastic platform to build on in using evidence if we work with our staff to enable them to continue to be up to date, to do the research that some of them are so passionately interested in, and to apply the results of that in their day-to-day decision making. It can provide a really constructive basis for a dialogue between payers and providers, a conversation that many of us will know can be both frustrating and sometimes completely redundant in the absence of a shared evidence base. If we've got in front of us a common shared evidence base in which we're all confident, then we are halfway towards getting the best deals, the best solutions for the investment decisions that our healthcare systems need to make to ensure consistency in the delivery of services. And finally, it enables us to measure and compare by extracting standards and indicators from the evidence base. We can make sure that we know what it is that we're doing, that we can be confident using those standards, that we're doing the right thing. And we can expose all that to ourselves, to the organizations, the systems, the political world that holds us to account, but most importantly, to the people who we work for and who rely on us, and to whom we all make individually and collectively a huge promise when we join and work for a healthcare system, which is that we will do the very best for you. That means knowing what the best for individual patients is likely to be, sharing that information with them, enabling them to join in the decision making, and to do that consistently, patient to patient, organisation to organisation, week to week, year to year. That way, I think, we can help to reduce variation and be confident that we're doing the very best for our patients. Well, thank you again for the opportunity to join you. I hope you have a great meeting and that you enjoy the rest of the day.